Pathology and pathophysiology of tuberculosis. It's my pleasure to speak about pathology and pathophysiology of tuberculosis, that is TB, a disease that remains a major global health challenge despite advancement in diagnosis and treatment. Tuberculosis, that is TB, continues to affect millions of people worldwide. So let's understand the mechanism of disease progression and pathology and physiology level. So the disease progression at pathology and physiology level is essential for better clinical management and research innovation. So first is the etiology and transmission. As you know, TB is caused by Mycobacterium tuberculosis, that is MTB bacilli, an acid-fast bacilli with a unique lipid-rich cell wall that makes it resistant to desiccation and many disinfectants. So transmission occurs primarily via inhalation of aerosolized droplet from the infected person or a sputum positive person. The bacteria reach the alveoli where they are phagocytosized or engulfed by alveolar macrophages. The body's immune response determines whether the infection will be cleared or remain latent or progress to active disease. So now let's start with pathophysiology of primary tuberculosis. The initial infection and macrophage response once inside the alveoli, Mycobacterium tuberculosis is engulfed by alveolar macrophages. However, the bacteria can inhibit phagosome-lysosome fusion, allowing survival and replication within the macrophages. Second is a granuloma formation. The immune system activate Th1, that's T helper cells, which release interferon gamma, that is IFN gamma, to activate macrophages. The activated macrophages produce tumor necrosis factor alpha, TNF alpha, and interleukins, leading to recruitment of more immune cells. These cells cluster around the infected macrophages, forming a granuloma, also called a tubercle. Inside the granuloma, infected macrophages undergo caseation or caseous necrosis, creating a central area surrounded by immune cells. Latent versus active infection, that is LTBI with active TB disease. In most individuals with a competent immune system, The granuloma remains intact, keeping the bacteria dormant. That is a LTBI, latent tuberculosis infection. However, in immunocompromised individuals, granuloma can break down, leading to reactivate tuberculosis with active bacterial replication. Now, the pathology of progressive and post-progressive tuberculosis. First is a progressive primary tuberculosis, mostly occurred in children whose immune system is not developed and the immunocompromised host like HIV, uncontrolled diabetes. Instead of controlling the infection, the immune system fails to contain it, leading to uncontrolled bacterial growth. Enlarged caseous granuloma, cavitary lesions in the lung. In children and HIV patients, primary TB can disseminate through blood, that is a hematogenous spread, leading to miliary TB. Tiny granulomas throughout the organ or throughout the body. TB meningitis, TB of the bone, that is a Pott's disease. B is a post-primary, that is a secondary TB in reactivation TB. Caseous garoma rupture into the airway, allowing bacteria to spread. This occurs after some time, maybe lifetime or 1 or 2 years. The hallmark pathology includes upper lobe cavitary lesion due to very high oxygen tension, which is favorable for Mycobacterium tuberculosis, caseous necrosis, fibrosis, and tissue destruction. There can be hemoptysis from the vascular erosion of bronchial artery. Immunopathology and systemic effect of tuberculosis, that is TB. Immune invasion by Mycobacterium tuberculosis inhibits antigen presentation by dendrite cell, delaying T cell activation. Alters macrophage metabolism, preventing bacterial clearance. Effect on host. Chronic inflammation leads to weight loss, fatigue, that is a tiredness, and night sweat. It is due to TNF alpha and IL-1 effect. Lung fibrosis results in decreased oxygen exchange, leading to hypoxia and respiratory failure in advanced stages or in advanced disease. In disseminated TB, oxygen dysfunction occurs in the liver, kidney, and brain. So, In conclusion, tuberculosis is a complex disease driven by the interplay between Mycobacterium tuberculosis and host immune response. The pathological hallmark of tuberculosis is granuloma formation. While it is pathophysiology involved in immune evasion, tissue necrosis, and systemic inflammation. Understanding this mechanism is crucial for improving diagnostic strategy, developing post-directed therapies, and designing effective vaccines. As we continue to battle TB, it is imperative to strengthen our understanding of its pathology to enhance patients' outcome and reduce transmission. Thank you.